We acknowledge the traditional owners of the land on which this podcast was recorded, the Wurundjeri Woiwurrung and Boonwurrung peoples of the Kulin Nation, and pay our respects to their elders, past, present, and future. Welcome to the podcast series of Raising the Bar Melbourne, curated by the Faculty of Medicine, Dentistry and Health Sciences at the University of Melbourne. This special health edition of Raising the Bar, held in May of 2026, featured 20 talks by some of Melbourne's leading healthcare experts and was held across 10 pubs and bars, all in one night. The speakers presented topics ranging from AI and cancer research to understanding ADHD and neurodiversity, helping kids sleep, healthy social media habits, the future of robotic surgery, and much more. In this episode, you'll hear Professor Margie Danchin talk about why vaccine confidence is declining worldwide and how rebuilding trust can boost uptake and protect those most at risk.
Hello everyone, and thank you so much for coming. It must be such a luxury to be Taylor Swift or Noah Khan and know that people will come to your concert. I was checking the list last night thinking, what if nobody comes? So thank you very much for coming, and I really would like to make this conversational, chatty. I'd love to hear your questions. Please, as I'm speaking, think of some of the questions you'd like to ask at the end. I think I'm chatting for about 30 to 40 minutes, and then we've got, 15, 20 minutes or so to have a conversation. But if you really would like to say something as I'm chatting, please put your hand up and I'm really happy to stop. I love this concept. I think Raising the Bar is fabulous to be here. And I must say this bar's really lovely. I wasn't sure where I was coming. Clearly I've been living under a rock for way too long, but this is just gorgeous. So welcome and thank you very much for coming. So is there anything more controversial than vaccines really at the moment? Maybe RFK Jr. and Trump, but we'll get to that. So strap in for a wild ride because I'm going to take you on a bit of a journey. And, I think people are questioning vaccines more than ever now since COVID. We know that there was never a point in history when vaccines were not more scrutinised. Everyone was an expert. Everyone was an epidemiologist. Everyone was a vaccine expert. Everyone was a vaccine safety expert. I certainly had a decent run in the media trying to explain some of these concepts and talk about some of the, vaccine safety scares, and I'm going to get to some of that a little bit later. But I think what we have to acknowledge is that we're talking about something that we're giving to healthy people. It's not a treatment. You're not in hospital. You're not in ICU. These are healthy children, healthy infants, healthy adolescents and older people, pregnant women, who we're asking to take a preventative therapy, a vaccine, and that's scary for a lot of people, and they're well at the time. And this goes way back to Edward Jenner and cowpox, but in fact vaccination goes back about 2,000 or 3,000 years. So it's not a new concept, but there has always been questioning and resistance to vaccines. But I think it is honestly now on hyperdrive, and that's partly because of social media and all of the online noise. And, the question is, how do we counteract that? So who am I? Well, I'm a mum of 4 kids, and that's really my first job in life, I feel. They're between 16 and 23, and they're all pretty annoying. I much preferred them under 12. I feel like I nailed that age group, but the teenagers, not so much. So I'm a mum of 4. I'm a doctor. I'm a paediatrician up the road at the Children's Hospital. I've been working in the specialist immunisation clinic there at the kids for about 20 years. So every Tuesday morning I speak with parents who have concerns about vaccines, whose child has experienced an adverse event, or a child who needs special risk vaccines. So they might have had a transplant or they're immunocompromised for whatever reason. So we have to design complex special risk vaccine schedules for them or whatever. So it's a terrific clinic. I love it. And we certainly cover many of the questioning and concerns that you see in the media, and I'm going to share some of that with you in a minute. So I'm a doctor, I'm a mum. But I'm also a clinician scientist. I lead 2 research groups at MCRI, one on vaccine uptake, and I'm going to share a bit of that work tonight, but also vaccine clinical trials, so testing new vaccines, new schedules, and I'm a member of ATAGI, and I'm sure all of you know about ATAGI now after COVID, the Australian Technical Advisory Group on Immunisation, which really sets the vaccine schedule across the lifespan for Australia, and I love being part of that really terrific group. But one of my bugbears about ATAGI is that their communication with the public is not great. So I'm excited to tell you, as of today, we've now formed a new communication subgroup where we're actually going to discuss about better communicating the deliberations and the ATAGI advice to all of the key audiences, particularly the public, but also GPs and the different stakeholders and specialty groups, which I think we really missed during COVID. So what I really want to cover today, rather than focusing on facts and numbers, I'm going to get a little bit to coverage and vaccine preventable diseases and things, but I really want to talk about how do we help parents navigate this really complex world of choosing to vaccinate their child? We know that parents want to do the best for their children. So if they choose not to vaccinate, it's not because they want to harm the child. It's for them that the risk of vaccines is just way higher and outweighs the risk of the diseases. And in many ways, I'm sure you would agree, vaccines are a victim of their own success. Many of the diseases that we vaccinate against, we just don't see anymore. But frighteningly, in the last year or so, they are coming back. So we are now seeing cases of diphtheria, polio, whooping cough. I mean, in the region, we're not seeing polio cases here in Australia, but it is not inconceivable that we will get clinical polio here in Australia, diphtheria. We're seeing massive escalations in whooping cough, RSV, measles from return travellers. So our world is actually changing. We don't live in a safe little bubble anymore. And I think that luxury that we have of choosing whether or not we will give our precious infant a vaccine is not going to be such a luxury for a lot longer. The vaccine coverage rates for children in Australia are the worst they've been in a decade. They have declined every year since 2020. So we're actually kind of in dire straits without scaring you, but you know, we have pockets around Australia. We normally measure vaccine coverage at 3 age time points, at 1, 2 and 4 years. We say 5, but it's actually 4 years. And so, you know, the classic one is the MMR, the measles, mumps, rubella vaccine. We do need about 95% coverage in the community to stop measles spreading. It's the most spreadable vaccine preventable disease that we know. One primary case of measles causes 18 secondary cases. So it's very easy to see how that can spread wildfire in the community in a totally unvaccinated population. Now, of course, we don't have an unvaccinated population in Australia, but we do have pockets where coverage of measles, MMR coverage, is in the mid 80% or even lower. In the Byron Bay region, the Noosa hinterland, parts of WA, coverage is down below, 70% or even lower. So when we have these escalating cases in the Asia Pacific region, which we do, we have an enormous number of measles cases, particularly in India, Indonesia, Vietnam in particular. People are travelling, they're coming into Australia, they're bringing measles, and if your child is in an area where coverage is low or region where coverage is low, they are at risk. And if they're under 12 months before they've even had the MMR vaccine, they are seriously at risk and can die. And I think people, sadly, I genuinely believe we are going to see a death from measles in Australia in the next few years. And that really just is heartbreaking when you think this is a completely preventable disease. So I think now, instead of seeing this as a bit of an esoteric concept, we actually have to take it seriously, because the misinformation and what's going on around vaccines is having real impact on children's and families' lives, and it's doing real harm. So I just want you to think about the real questions that we're sort of facing right now. First, I would say, how do we acknowledge risk and transparency and respect parents' questioning? And how do we balance trust? Because at the heart of this issue is trust, and I'm going to get to that a little bit later. It's not enough to throw lots of information at people. That's not going to change their mind if they have genuine questions and concerns. It's far more about, do they trust the messenger, whether they will accept. And that's what I experience every week in clinic. I can feel when a family trusts me and when they're actually listening versus putting their hackles up. It's a complete change in the mood in the room. We need to talk about how to deal with mis and disinformation. So misinformation is information that is spread that is incorrect, it's not true. Disinformation is deliberately spreading false information to cause harm. And I think you could argue that that is happening a lot with the current US administration, with Trump and RFK Jr. They are spreading, whether it's deliberately to cause harm. So for example, RFK Jr. came out and was spreading very broadly in the US mid last year that giving vitamin A was as good as giving the MMR vaccine to prevent measles. And in Colorado, one of the deposed members from their ATAGI equivalent, it's called the ACIP, who's the head of the Infectious Disease Committee of the American Academy of Pediatrics, and he lives in Colorado. He was sharing with me, and of course this is not reported, that their hospital was being inundated with young children who were coming in with vitamin A poisoning and neurological damage because families were giving so much vitamin A so that they didn't have to give the MMR vaccine. Now that causes real harm, to think that we are giving people completely false health information. And it astounds me how RFK Jr. is in the position he's in, given the information that he imparts. I'm sure you've all seen, or maybe you haven't, but if you want to Google the US CDC website and look at their current statement on autism and MMR vaccines, it currently says that we cannot claim that that vaccines do not cause autism. It is not an evidence-based claim because studies have not ruled out the possibility that infant vaccines cause autism. Now, this has caused questioning, drop in MMR coverage in the US and globally. We have evidence now in Australia that that is actually affecting Australian parents' confidence and trust in childhood vaccines, because for an institution that's been so previously revered and trusted, such as the US CDC, to come out and say that we can't say that vaccines don't cause autism is just unbelievable. And I can share some of the science with you if you're interested, but it is irrefutable, and we have more than 25 years of research to show that vaccines do not cause autism. So how do we deal with misinformation and disinformation and people in power who I would argue are deliberately spreading this disinformation? Maybe it's what they genuinely believe, which is even more distressing. And then, of course, vaccine safety. I'd like to share with you a little bit how seriously most countries, and particularly Australia, actually takes measuring vaccine safety, looking for vaccine safety signals, and how we can do that better to reassure the public that we are really cognizant of the fact that vaccines, like any medicine, have side effects. They have common and expected side effects. We know that. Fever, irritability, crying, an injection site reaction, rash. 15 to 20% of babies will have those reactions. But that doesn't mean that the vaccine was faulty or toxic. We need to help families to realise that's okay, that's normal. That means the immune system is being stimulated. But there are some rare, more serious side effects, which I'm going to talk about in a second. And there are also, sadly, quite devastating, very rare adverse events that do change the shape of a young child or an adult's life, and really asks the question why Australia does not have a vaccine injury compensation scheme. We are one of the few countries in the world that does not have a vaccine injury compensation scheme, and yet we ask families to vaccinate their kids, and in the very, very, very rare instances where their child is harmed, we don't compensate them appropriately. So let me share with you some personal stories. Firstly, I come at this I'm very passionate about this space. I always worked in in infectious diseases and vaccines. I worked on the infant rotavirus vaccine program at the Murdoch Children's Research Institute with Professor Ruth Bishop and Professor Julie Bynes and Graham Barnes. That's the neonatal oral rotavirus vaccine that's actually just about to be rolled out in Indonesia, which is an extraordinary success story of a vaccine being developed from an academic institution. So I've worked with vaccines for a very long time, since I became a baby PhD student and a postdoc. But it was in 2013 when I saw Sonia Pemberton's jabbed Love, Fear and Vaccines that a light went on for me, and I was like, I have to work in this space. Can I ask you to put your hand up if you saw that documentary? Oh my goodness, only one person. Okay, homework. If you could just put in your notes. I watched it again the other night because I was thinking about this talk and I was like, oh my God, that really changed my life. Watch Sonia Pemberton's Love, Fear and Vaccine. Jabbed, Love, Fear and Vaccines. So she's a documentary filmmaker, arguably one of the most awarded and revered filmmakers. She also did for the Doherty the COVID documentary with Professor Peter Doherty. I can't remember the name. Cracking COVID. Did you watch Cracking COVID? Yep. Well, that's Sonia Pemberton. She's amazing, absolutely amazing. So I watched Jabbed in 2013, and she did this really elegant balance of depicting the diseases and some of the severe and serious consequences that they had for children, but then also balancing that against some of the adverse events that vaccines have had. So, for example, when we think of some of the historical serious adverse events that have really rocked vaccine confidence, the one that really comes to mind for me is the polio vaccine. So in 1955, the Salk polio vaccine, inactivated polio vaccine, was manufactured in the US. But there was a manufacturer called the Cutter Group, and it's now called the Cutter incident. And unfortunately, in the manufacturing process, the inactivation was not done correctly. And so there was sort of a weakened form of the virus that was still live and attenuated. And 200,000 children were affected, and 200 kids in the US were paralyzed in 1955, and 10 died. Now, that is an absolute tragedy, and that happened, and so you can imagine what that did to vaccine confidence in the US. And even now with the polio vaccine, we have something called VAP, vaccine-associated paralytic polio, which occurs in 1 in 3 million doses of the oral polio vaccine. And that's usually in communities with low vaccine coverage rates. And again, it's the weakened virus in the OPV that can mutate and cause paralysis. And that is estimated to be about 500 cases a year globally. So now most countries have a combination of the OPV, oral, and the IPV, inactivated polio vaccine program together. So that has become a lot more rare. But, these are serious adverse events that rock vaccine confidence, and we need to own that as a scientific and medical community. Thankfully, the Cutter incident was a very long time ago, but we need to be honest about vaccine safety, and we can't oversell vaccine safety. I feel like we lose the public when we stand in front of the media and we say vaccines are safe and effective. And, I think we need to acknowledge that they have side effects. Most of them are common and expected, but there are sometimes serious adverse events. And as I say, I really believe that we in Australia should compensate people if they are unfortunate to experience that, and we don't. And that is something that we're still fighting about on ATAGI. So let me share a personal story with you. I am one of 3 kids, and my younger sister is 7 years younger than me, and she lives in Mullumbimby, and she's an anti-vaxxer. And so Christmas is really interesting at our place, and her daughter is now 17, and in COVID, she was 14, she came to me, and my sister separated from my niece's dad, and they wanted to travel to Japan because he's married to a Japanese lady. And for my niece to travel, she needed to have a COVID vaccine. So she came to me, she's completely unvaccinated, and she said, Auntie Margie, can you help me? I really want to have a COVID vaccine. I want to travel. I want to protect myself, but you know that mum's against vaccines. Do I go against my sister's wishes? She is clearly anti-vaccination. She says that I don't know anything about vaccines. It's fine. We don't talk about it. But, do I go against my sister's wishes and help my 14-year-old niece to get vaccinated on her own? I told her that was an option, but I said I couldn't make that happen for her. I just felt, I'm not sure. I'd love to know. I'd love to have a show of hands whether you had any of this conflict in your families over COVID. Anyone have a family member that refused to get vaccinated? Right. So really stressful. So anyway, I told my niece that I would love to help her. I would tell her where she could go, but I couldn't make it happen for her. And that was her decision. And she had to think about her relationship with her mum. Anyway, sadly, she decided not to vaccinate, and she didn't go with her dad to Japan and her half siblings. And that was really sad. And she still remains completely unvaccinated. And then at the end of that year, my sister came with my niece to Christmas. And my dad at the time, very immunocompromised with Parkinson's disease, my mum with multiple myeloma, immunocompromised, and we had this long table outside where mum and dad were up one end and my sister was down the other end, and my dad would not speak to her unless she had a mask on, and it was just like, sort of a war of the roses or something. And it was so stressful. And here me, the supposed vaccine expert, I was like, it's okay, the risk is low, we're outside, it's good, would you like a drink? And Dad's like, she can't come near me without a mask. And it was just awful. Anyway, so, but this is the reality. We create so much fear and division and judgment. And, one thing I've really learnt through all of this is we have to hear people out. We do have to respect their wishes. We need to try and work with them. And so I think that's what I would say. What I've learnt is that vaccine decision making, like many other scientific decisions or embracing of science, is led by people's cognitive biases. And what I mean by that is those mental shortcuts where you make a decision. So, for example, availability bias. I don't know whether you remember in COVID, but remember when people were having the blood clots in the brain from the AstraZeneca vaccine, the younger adults, the TTS, thrombosis with thrombocytopenia syndrome. So, that occurs roughly in about 3 per 100,000, pretty rare. But, it was everywhere. You would have thought at that point in time in the media that anyone could just drop dead in front of you with a blood clot in the brain. Like, it was just so amplified. And so people completely misinterpret the risk. If you think about a risk of, let's say 1 in 100,000 for TTS, which is probably what it was more closer to, that's one person in the MCG. One person in the MCG would have had a clot in their brain from the AstraZeneca vaccine, because it was only the adenoviral vector vaccines that caused that, and it was only in younger individuals. So that's why the AstraZeneca vaccine was then moved to only people for over 60, and everyone under 60 got the mRNA vaccines, and everyone was up in arms. But it's that real availability bias, and we all do it. We all use subconscious mental shortcuts to interpret risk. So that's one way we interpret risk. The second is with our values. And there's really elegant work and research to look at values in vaccine decision making. There are some people, who live in more alternative communities who have this sort of purity value where they only want to eat things that are natural and macrobiotic and cloth nappies, and somehow a disease is more natural and therefore one should get that rather than have the vaccine, even though they might die from it. But that is honestly the way parents explain it in clinic, that they would prefer their child to get sick with a natural disease than have a vaccine. So we need to think about values, cognitive biases, and their worldview, how they interpret risk. There are some people who are just terrified of getting on a plane or going on a motorbike. Other people are completely happy with that risk. There's also our personal experiences. We are so influenced if someone in our family has had a serious adverse event or a nasty reaction to a vaccine, or someone we know. Our culture, there are many distinctive attitudes that I hear regularly from Indian, Somalian cultures, Vietnamese cultures, very distinctive ways of thinking about family and risk and values and so on. And of course, politics. So when you put all of that in the mix, it's not hard to understand why this is such a mess and so complicated to navigate. So I told you about my niece, but then in terms of clinic, so I had clinic on yesterday morning. I had a mum come in with a 4-month-old little baby, gorgeous little girl, with her husband, completely distraught because after the 6-week vaccines, about 6 hours later, the baby became completely pale, floppy, and just not responsive. And they had left their GP practice and gone home, and the child was just completely unresponsive. So they called the ambulance. The ambulance came. The baby had a nice strong heartbeat, and after about 15 to 20 minutes came back, was pinker, and then had a feed. And the child was taken to a local emergency department, and of course they were screened for sepsis and other infections, and the baby was fine, and within about an hour was completely back to normal. Now we know what that is. Does anyone know what that adverse event's called? Anyone heard of it? It's called an HHE, hypotonic, hyporesponsive episode. It was much more common after the whole cell pertussis or whooping cough vaccine. Now we see it most commonly still after the first DTP vaccine at 6 weeks, less common with the acellular pertussis vaccine, which only has a couple of components of the Bordetella pertussis bug, not the whole bug as the whole cell. But this, we don't actually know what this adverse event actually is. We think it's an abnormal response from the immune system. It does not harm the baby. It does not harm their brain. They completely recover. The recurrence risk for dose 2 at 4 months is about 3.5%. But it is incredibly frightening for a parent, as you can imagine, if that's your baby, when you see them pale, floppy, and unresponsive. And so I would say, I mean, the incidence of that is probably about 1 in 40 to 50,000, but I would see families in clinic not infrequently who present with that adverse event and talk them through it. And what we do is we offer those families admission overnight in our short stay unit at the Royal Children's Hospital. And they come in, they have dose 2, they stay overnight, we monitor them and we let them go in the morning. And I actually haven't seen a recurrence, but it just gives the family that confidence that we're there, we've got them, and we explain that it's not harmful. But it's pretty scary, and I've had many, many families. In fact, the mum yesterday was in tears, just remembering and recounting what it was like to see her baby like that. So, you know, those are some of the adverse events that are clearly scary and that we need to support families through. There's another one that we see not infrequently, sadly, which is where we see a child who's had a vaccine proximate seizure, so a seizure with a fever or without a fever, within a day or two of getting their vaccines. And this is very scary as well. Febrile convulsions are common, but if it's a seizure that happens with no fever, an afebrile seizure, that's a little bit more concerning. But there's a group of children that have a syndrome called Dravet syndrome. Has anyone heard of that? It's a genetic epilepsy. It has a mutation called SCN1A, and it's really nasty. And Professor Ingrid Scheffer actually diagnosed the gene and actually isolated the gene in this condition. But unfortunately, the first time these particular children have a seizure is with a vaccine, because a vaccine, like a virus, causes a fever, and so it stimulates the immune system. So this concept explaining to a parent that no, your child has a gene that causes an underlying seizure disorder and developmental disorder, and the trigger was a vaccine, a fever. It didn't cause the seizure. So, you know, that's another really complicated conversation that we have with families. So you can see, I mean, I could talk all night about the sorts of adverse events and conversations I have with families. I talk a lot about HPV vaccine. There's so much concern that some parents have about promiscuity, for giving their daughter or son a sexual health vaccine when they're not sexually active. That's a really common conversation. I can't not mention the MMR and autism catastrophe, which is what I call it. So if you don't know, I'll tell you in a nutshell that this controversy started in 1998 when Andrew Wakefield published a study in The Lancet of 12 children, and he drew a link with falsified data between the MMR vaccine and children having developmental behavioural changes, communication difficulties, i.e. autism. And of course, we all know that The Lancet retracted that paper in 2010 and that Andrew Wakefield was deregistered as a medical practitioner in the UK and couldn't work globally as a medical practitioner, but the damage was done. We still now, today, in the work that we do, the Australian public, 10% of the Australian public still believe that the MMR vaccine causes autism. So I would have that conversation probably most commonly in clinics still, because what happens is, about a quarter of kids who go on to develop autism develop the signs of autism at about 15, 16, 18 months. And guess when they get their first MMR vaccine? At 12 months, and the second dose of MMR at 18 months. So this really complex concept of causality, just because two things are associated temporarily in time, doesn't mean one thing caused the other thing. So that's a really hard thing to explain to a family. Like if I eat a banana and then I don't know, pass out, did the banana cause me to faint? And people just can't really necessarily grasp it. Just because the baby had a vaccine at 12 months and then they had some developmental regression at 16 to 18 months, it didn't mean the MMR vaccine caused that. And so, of course, now we've got studies like the two most common studies are the meta-analysis in 2014, which was 1.2 million kids that showed no association, and then in 2019, one of the largest prospective cohort studies, a Danish cohort study of about 660,000 kids, no association between MMR or any vaccine and autism. So we actually do have the evidence. So when the CDC comes out and says we can't be sure, to the people in the field and the scientists who've worked in this space for so many years and see the benefit of vaccines, it's just heartbreaking the damage it's done. So that's some of the concerns, and I think you would agree with me that it's fair for people to have some concerns about vaccines. Some of those things are scary and they do happen, and we need to acknowledge and we need to be able to help parents understand what's happened and make a decision about continuing vaccinating. And I'm happy to tell you that most of the families I speak to in clinic do go on and continue to vaccinate, but I have been doing this for 20 years. The second thing around misinformation, and I think this is a really key concept, not everything is misinformation. Some of it is actually a genuine concern, and I think sometimes we're too quick to label things as misinformation. True misinformation, I'm sure you saw through COVID, put your hand up if you saw the whole fascination around microchips, the mRNA vaccines, putting the microchip in your arm. There were these videos that were circulating from Fiji with people putting getting spoons to stick to their head and their arms, from the magnetism from the vaccines. And then, it was shown later that was actually honey that they were using. I don't know how the honey got it to stick, or I don't know what they used, but somehow that spoon stuck on their skin and it was not due to the vaccine. So there is genuinely this nutty misinformation that circulates. I talked about the vitamin A issue. There are so many examples. The whole MMR and autism thing is just a disaster, and it continues and it's so pervasive. So as I said, just very briefly, we have seen a massive escalation in vaccine preventable diseases in the region, and it's really, really heartbreaking seeing the measles cases and the outbreaks, particularly in like the Philippines, Indonesia, Vietnam. Kids are dying. I work very closely with DFAT. We work in 6 countries in the Asia Pacific region to improve confidence and trust in vaccines. And I'm happy to say that we have really great, robust data now to show that our programs, our community engagement programs, really do change people's intention to vaccinate and then their decision and actual vaccination of their children. And as I said, coverage has declined in the region. I'm not going to bore you with figures. There was some recovery after COVID we saw globally, but unfortunately now it's declining again. And there's some really elegant studies coming out showing that what's happening in the US with the Trump administration is impacting vaccine confidence globally. And I'll just leave it at that. If you want to look further, Heidi Larson and the Vaccine Confidence Project has done some really great work, and I'll mention some of the work we're doing in the space as well. So I think it's fair to say, you would agree with me, the world has changed. We are living in a post-COVID era. The scrutiny on vaccines and on vaccine safety has never been more prominent. And I don't think that's necessarily a bad thing. I think people should ask questions. I welcome questions. I don't say to a parent, do you have questions? I say, what questions do you have about vaccines? I assume people have questions and I really welcome them. But I think what we see in the community, a lot of our GPs and a lot of our healthcare providers are a bit de-skilled. The vaccine schedule is complex, and to be able to answer all the questions about the adverse events and the different vaccines is really challenging for doctors and providers. But we have really strong evidence now that over half of parents have concerns about vaccines. So I'm going to ask you now, who in this room has some concerns about vaccines? Can you put your hand up? That's great. I'm glad you were brave. So no one else has any concerns about vaccines. Oh my God, I'm totally talking to the converted here. Can you come to clinic and help me out? That's great. But, you know, at least 50% of the population have questions. If we look at the vaccine acceptance spectrum, and this is a really nice concept to sort of get your head around, as you can imagine, most people are accepting, but we still need to make sure that they have informed consent when they choose to vaccinate their child. Then there's a much smaller group that we call vaccine hesitant. So these are people whose child has had an adverse event or someone in their family and they're really worried, but they want to vaccinate, but they've got questions. And that's probably about 12 to 15%. Then we have what we call our cherry pickers. So these are the people that just want this one and just want that one and they just want their schedule and they want them a month apart and they don't want that. And oh my God, give me strength. I had one of those yesterday. But we got her across the line and she started. And then, you know, because what I feel is that every conversation matters. If I can get her to vaccinate that baby, all the other kids will be vaccinated. Her mother's group's children will be vaccinated. So I can't give up, even though they sometimes completely drive me nuts. I can be more honest now, given that no one has questions. And then, of course, we have the complete anti-vaxxers, the refusal. And that really sits pretty steady at about 2 to 3%. So that's what we call the vaccine hesitancy spectrum or vaccine acceptance spectrum. But what I want to talk to you now about is, well, okay, so what do we do about this? I've talked a little bit about some of the things we do, but what I want to talk about is how do we actually tackle this issue? So number one, with the vaccine accepting parents, I think we still need to have really good informed consent. And there's some terrific things that were developed more strongly during COVID, decision aids. Many people are very visual. As I said before, when we're talking about a risk, so going back to the hypertonic and hyper-responsive episode, maybe half the MCG, so 50,000 people, 1 in 50,000 people, or babies, if you had 50,000 babies in the MCG, 1 would have an HHE. So people can actually imagine the magnitude of that risk rather than just throwing numbers at them, because there's a lot of data to show that people just can't get their head around big numbers, especially if you use a different denominator. So we have to use a consistent denominator, we have to use visual aids, decision aids, we need to relate it to things that people can understand, and then they really get what we're talking about. So like I said to you before, with the TTS, with the clots in the brain, that risk was about 1 in 100,000. Do you know that the clotting risk from the brain, the clots in the brain from COVID infection itself is 40 times higher? So the risk of getting a clot from COVID infection in the brain is 200 in 100,000. Now, why didn't we get that out in the media? Why weren't we helping people to understand that this was a real risk and it was a serious adverse event from AstraZeneca vaccine, but actually getting COVID infection was way worse? I don't think we do that very well. So actually having informed consent, explaining relative risk, and then my passion is really about having effective conversations. So we have developed a program called SKY. I encourage you to Google it. It's called Sharing Knowledge About Immunisation. It took us about 5 years to develop. It's Commonwealth funded. It's in every general practice across Australia. And what we do is we have resources and fact sheets and frequently asked questions across the lifespan. It's pregnancy, infant, adolescent, and then adult vaccination, and then a whole program for Aboriginal and Torres Strait Islanders. And it's just really nice, simple information on these FAQs. And then we link to more detailed studies if people want much heavier information and scientific information. So there's SKY. There's a lot of evidence on how do we address misinformation with pre-bunking, debunking, teaching critical thinking. And my program that I'm particularly passionate about, I mentioned we work in the Asia Pacific region. We have something called the Vaccine Champions program, where we train healthcare workers as well as diverse community leaders, so religious leaders, the fatwa in Indonesia. In Fiji, we trained Fiji rugby and cricket. We trained teachers in Tonga for the HPV vaccine. So diverse numbers of community leaders. We give them the vaccine knowledge and education as well as the communication skills, some of what I'm talking to you about now. We get them to do role plays, we observe them, and then they go into the community and they run sessions like this. And it has been unbelievably effective. So DFAT is still funding it, Vietnam is still continuing it, as is Tonga and Fiji. And we're co-designing a program like this for schools in the Philippines. So, and why does that work? That's because they don't want to hear from a white lady with curly hair in their community. They want to hear from their leaders, the people they trust. So if you come in from the ground up and the trust is there, because so often it's about how we communicate and what we say, and not the actual information, it's how we communicate it, and trust is the essential ingredient. So really happy to share more about the Vaccine Champions program, but it's just such a passion of mine. Then we need to help families and parents understand the diseases. So for meningococcal disease, for example, a child, an adolescent, can be dead in 15 hours. So if they don't have their MenACWY or they don't have the meningococcal B vaccine on board and they get infected and they go to bed at 10 p.m. at night and their mum finds them at 6 or 7 a.m. the next morning and takes them to the emergency department, it's frequently too late. They are dead 3 hours later. And that's because these infections are overwhelming. You need the antibodies on board, ready to fight, ready to go. It doesn't matter, you hit them with antibiotics, they still die. And that is an absolute tragedy. And we need people to understand that. We don't have the luxury with certain diseases to, sort of pontificate and wonder whether we should be vaccinating. I've talked about rare adverse events and the fact that we don't have an injury compensation scheme. We need to support vaccination. We now have a protocol for those Dravet kids I mentioned to you before, where we admit them to the neurology ward. We give them anticonvulsant and Panadol every 4 hours, and we are able to vaccinate those kids and they don't have a vaccine proximate seizure, and we can protect them from the diseases, and we're just publishing that work. And then the last thing is medical exemptions. This is another thing I'm very passionate about. There's a lot of inequity about granting of medical exemptions. If you come to my clinic, the specialist immunisation clinic at the Children's, and you explain to me that your child has a rare autoimmune disorder or seizure disorder, and you're really worried that if you vaccinate them, they might have another seizure or they might have a relapse. We don't necessarily have the evidence to know whether vaccines are going to cause a relapse or a seizure or not, but that's a reasonable concern to me. I'm likely to give you a temporary medical exemption and ask you to come back and work with you around that. But you might go to a GP who says, no, the only medical exemptions I can give you are for immunocompromise and anaphylaxis. I'm sorry, you can't have one. And then you go and vaccinate your child and they do have an adverse event. And we see these in clinic all the time. And I think we need a far more equitable, fair process for people to be evaluated for medical exemptions. That's another big space. So I'm going to finish now. Really would welcome your questions and comments, but I'm going to leave you with 3 thoughts. I really am passionate about the fact that we can't just give people knowledge and facts. It's not going to work. You can't. Do you remember the Arm Yourself campaign in COVID with the Band-Aids that was on telly with no heads? $11 million that campaign cost, and it did nothing. Now imagine what I could do with $11 million with a Vaccine Champions program in an Indigenous community in the Tiwi Islands, where I train the leaders from that community to speak to their people to help them vaccinate. So we need to actually be able to tailor the solutions to the problem and use our resources well, and we need to acknowledge the role of trust and communication. We can't just throw more knowledge. Secondly, we need to teach critical thinking. This has got to start in schools. We've got to start helping people to identify what is misinformation and don't share it. What is that critical thinking? There's some really cool games that teach people to identify. There's one called Cranky Uncle around vaccines, where you can get points if you tell Cranky Uncle off because he's spreading misinformation, and you identify the tactic that he's using, like false expert or cherry picking or whatever it is. That's kind of cool. We've just done a trial on that. So, and I think the future is really about education in schools. The future parents are our beautiful kids in secondary school, our uni students. We need to be working with them. We need to be giving them confidence, information, trust in vaccines, because they're going to be making decisions for their kids, and they're going to be the future and the health of our society. So thank you so much, and I look forward to your questions.
Thanks, Margie. That's a great talk. It just echoes so much of what I see every day as an obstetrician. And it's more and more people are doing their own research. My heart sinks when I hear that. I'm really interested to hear how you're trying to overcome that. But once someone's pregnant, it's a bit too late to sort of start back at school with critical thinking. We've just lost the expertise, the value of trust in expertise, and I don't know how we overcome that, because we're fighting against social media. If anyone's got any ideas, please tell me.
That trust element is really, really critical. And so we have a whole framework that we teach in our Vaccine Champions program about how to have a vaccine conversation, and that's very much based on motivational interviewing techniques. And it really starts with trying to understand where they are on the spectrum, and then listening, and then like reframing back to them, just checking that you understand their concern, asking to share your knowledge, and then pointing them to information, trustworthy information. And when you go through a process like that and you're warm and you don't judge, you can feel the hackles coming down. So I don't know that it's so much about expertise. I think they're just genuinely frightened. Something's happened historically, a friend, a family member, something they've read, they're terrified. And so they come in. I mean, I've had families walk into clinic with briefcases of papers telling me how bad vaccines are and they want a medical exemption. I've had one dad stand up and yell at me and say, I want a medical exemption now. I'm not vaccinating. My child can't go to kinder. And I was like, I had to call a code grey. I mean, I don't normally like to call a code grey. I can normally talk them down, but this dad I couldn't. And in fact, a colleague at Monash actually had a father pull out a gun a couple of years ago. So people get very passionate about this stuff. And I think it's really about that connection and about that trust. And we can't always overcome it. But what I can tell you is facts don't always get you across the line. If they believe you, if they think you have their best interests at heart, you'll get them across the line more than if you bombard them. I mean, I always direct them to the Sky website, the National Centre for Immunisation Research and Surveillance resources, depending on the level of information they want. Some people want really heavy scientific information. Some people want really clear explanations. But I don't and often I'll put up the NNDSS, so that's the National Notifiable Disease Surveillance System data, where I show them this is how many cases of measles we have in the under 4s in Australia this year compared to last year. And like when I'm trying to show them that actually these diseases are around, and I really try and talk about the diseases because they actually don't know what the hell they're vaccinating against. They don't know what pneumococcal, meningococcal, whooping cough, they don't know what it is. So sometimes it's facts. I think it's more about how we relate to people.
Hi, Margie. Thank you so much for your presentation. And I think, the work that you do with your team, it has really helped us during especially COVID. And then, trying to navigate those conversations with people in the community. And that's really been something that, I've always taken with me at my workplace. And I think something we've really emphasized, even moving across to research, is it's about how do we translate, medical research and ensure that there is increased confidence among community members, especially with community leaders, but also not fueling to disinformation or misinformation. I think that's been something that's been rather tricky in that space sometimes, like when we are trying to, address some of these issues, like concerns and relatively real concerns that community members have. And how do we then bridge that gap?
I think what it really comes down to, and I wanted to spend more time on the community engagement, but it really is about engaging the community and that co-design process. So, we might do a piece of research, qualitative research, where we understand what the concerns are, but then discussing it with community and getting their perspective and their ideas on solutions, and that whole co-design piece, not telling people what to do, listening to the historical perspectives and the other elements. And as I said, the decision-making that people have is so complex when you think of all those cognitive biases and values and worldviews and what's happened in the past and what their culture is. There's a lot to... I really think it comes back to listening. And I think governments don't do that very well. I think, you've probably, for those of you who are involved in research, seen the NHMRC guidelines that have just come out about consumer engagement in all research, and I think it's absolutely critical. Consumers the public need to be involved in every step of what we do and every solution and the evaluation and then the implementation. It's just critical. So you're right, but I think once you start talking to different communities and understanding, like some of the work that we've done, particularly in the Philippines, has been so interesting with communities when you just sit and listen to what the concerns are. I mean, I was really shocked, even in Indonesia, that the most pressing concern for parents who refused to vaccinate their child was that the father felt that the child was sick from the vaccine because they got a fever the next day. And I'm like, oh my God, did no one actually explain, or did he not understand that that is an expected reaction from a vaccine about the immune system working? And the father, so the role of gender is really important to consider. The father is the decision maker in the household. So it might be fine to have the mum come to the clinic, but if the father says no, then, we're not going to, you can't vaccinate. So I think understanding all the factors at play, a lot of the work we're doing, we're really working hard to engage fathers. Oh my God, it's so hard. But we're trying to get them to the antenatal clinic appointments, involved in the conversations, understanding, the vaccine safety and the side effects. So I think it's about talking to people and communities and really working out what's driving the decision making in that particular group of people. Yeah.
Thank you for the talk. You talked about adverse events and how people kind of feel and react if they know somebody who's had an adverse event. I'm wondering about the other side of that, and I guess this is to a certain extent a plan B, but wondering how people react if they find out in a community that people that haven't had vaccines and then have actually had, I guess you call adverse events from the actual illness. I'm thinking about places like, Fremantle and Byron Bay and Mullumbimby that have low vaccination rates. and whether that is actually something that could be potentially promoted more, that people in that when people. So I guess one thing I've got in mind is in the US with the measles outbreak, and I don't know what the evidence is, but I think it might be right. Then some people have gone back to looking at vaccinations when there's been a measles outbreak, because they're kind of concerned. So I'm just wondering if that
absolutely.
factors into it.
Well, definitely. Once the diseases, there's actually a really nice diagram that shows, the interrelationship between vaccination and when coverage goes low and the diseases come back, how, acceptance starts to go up again. So when people start experiencing the diseases, they definitely change their mind. Sorry, I've got a tickle. But it's really interesting you say that. I don't know whether any of you saw the piece, the op-ed in The Age that I contributed to a couple of months ago, where we found out a journalist approached me and said, was I aware that on certain sort of anti-vax chat groups, immunisation nurses and GPs were offering, if families paid $3,000, the GP would falsify their Australian immunisation record to say that the child was fully vaccinated when they had not received a vaccine. So the GP was basically taking $3,000 to falsify their records. And we came across these chat groups. We screenshotted all of the comments. We couldn't speak to a parent. But that is astounding to me. So you send your child to a kinder. So to attend kinder, your child has to be either fully vaccinated or on a catch-up schedule. That's the no jab, no play, and we have that here in Victoria. So if a parent goes with falsified immunisation records and then their kid has pertussis or chickenpox or whatever, measles, and infects the other kids in the kinder, because we know vaccines aren't 100% effective. I just think that's absolutely outrageous, and that is happening in Australia today. So these are the sort of things we've got to weigh up. But you're absolutely right. Once we see the diseases, people's thinking shifts. They are now more frightened about the diseases, but I hope that we can start talking about the diseases more. As I said, vaccines are a victim of their own success. Why can't we help people to recognise what the diseases do before their child gets the disease? And I don't know that we're very good at that. As I said, I think, and I have very trusted GP colleagues that tell me this, a lot of the current GPs are not well trained in this. They can't speak to the parents necessarily about the diseases or about the complexities of the vaccines or some of these safety issues, and that's fine. There's a specialist immunisation clinic in every state. So, we're at the Children's, there's one in Sydney, there's one in Adelaide, all around Australia we have one of these clinics, but not everyone can get to our clinic to talk about an adverse event or concern. So we're working closely with the Commonwealth. I actually sit on the Commonwealth Committee for the National Immunisation Strategy, and you'll be happy to know that we're designing training for all GPs and healthcare providers on some of the stuff I've been talking about, the Champions program stuff, the knowledge and the communication skills to really speak with parents. So hopefully we can move the needle. But as I said, the vaccine coverage rates in Australia are the worst they've been in more than a decade. So it's pretty scary.
Thank you so much for today. So my name is Miriam. I work with communicable diseases, vaccine preventable diseases. So we deal with measles outbreaks, pertussis. And I guess my question is, I have seen the hesitancy in vaccines and the cases that we get, and obviously always looking up whether they're vaccinated or not, looking up their household and the threat to the community and so forth and so on, especially within our measles cases. I'm just wondering in terms of because I don't have the expertise in terms of the vaccinations and kind of that clinical education in terms of, the efficiency of disease or, the vaccines and everything else like that. Where would I refer these families to? Because I know that, if it's pertussis, I do see post-COVID that they're vaccinated 3 or 4 of their other kids, but not this particular child. And then we see it, under 6 months or, under a year. And so this child is unvaccinated, whereas the other children in the households are.
Yeah, definitely. COVID definitely damaged vaccine competence.
And so the same with
in childhood vaccines, I mean.
Yeah. And so...
Look, it's a really good question because not everyone... I live, eat and breathe this stuff, right? So, but if you don't have some of this knowledge at your fingertips, it can be very stressful. And I think that's what happens a lot, as I said before, about the judgment that people feel when they go to speak to their GP. I had a family yesterday who, it was so interesting. The child was 4, her daughter was 4, and she had given the baby the 2 and 4 month vaccines, and then a woman in her mother's group, the child had developed asthma. It wasn't clear to me whether it was the same age child or an older child. And so everyone in the mother's group decided that vaccines caused asthma, and they all stopped vaccinating until the child was 4. And she'd gone to the GP multiple times in Warrnambool and had been judged and called an anti-vaxxer. And so she said to me at the start of the consultation with me, she said, "Please don't judge me. I really have questions and I'm too scared to speak to the GPs in Warrnambool, and I really want you to help me to understand whether this is something I should be worried about or not." And by the end, she was on a full catch-up schedule for the 4-year-old, and they were totally getting vaccinated. And so I think, wow, like that's a real issue. But that's also not a hard thing to counsel about. But some of what you're asking about with measles, I would point them to the SKY, the Sharing Knowledge About Immunisation website. It's all broken down there by vaccine, frequently asked questions, and each question has got a downloadable PDF fact sheet that you can print off, give to the family. It says who developed it at the end. We tried to really acknowledge the trust issue, because a lot of the time if you give people a fact sheet or something, they think it's from a pharmaceutical company. So the SKY fact sheets, but there's also the MVEC, Melbourne Vaccine Education Centre. There's NCIRS, National Centre for Immunisation Research and Surveillance, NCIRS, and there's also CHOP, the Children's Hospital of Philadelphia. So they're the 5 that I use. Personally, I like ours the most, SKY. And the Commonwealth have funded it, and we're expanding it, so that's kind of cool. And we're really trying to get into schools and school-based education with this stuff. But not everyone needs to be a vaccinologist. As I said, it's really about that message. Just 2 or 3, like in the programs we do in the region, we give people 2 or 3 key facts about the vaccine and 2 or 3 key facts about the disease. And that's often enough to reassure someone that vaccinating is a good idea. So I think it's hard. It is hard. So hopefully with this training that we're developing with the Commonwealth, we will be able to develop a lot more competence in these sort of conversations for GPs and immunisation nurses. They all say they struggle with it. And they all say they get very put off when someone is very aggressive. When a parent is very aggressive and angry, they all just freeze. So tricky.
So thank you to Margie. If you'd like to give her another round of applause.
Thank you for listening to the podcast series of Raising the Bar Melbourne, a special health edition. If you want to listen to more Raising the Bar talks, head to rtbevent.com/podcasts.